Okay. All right, everybody, we'll go ahead and get started. So we have Dr. Chrystal Fullen here with us today. She is a clinical neuropsychologist serving in the departments of both psychiatry and trauma surgery at UAMS. Dr. Fullen graduated from Our Lady of the Lake University with a doctorate degree in psychology and completed fellowship at UAMS, where she furthered her specialization in brain injury, rehabilitation, and program development. We are excited to hear her talk today, titled Traumatic Brain Injury in Arkansas, Trends, Symptoms, and Resources. With that, we'll give it over to Dr. Fullen.
Thank you, Dr. Bars, for that kind introduction. So everybody, my name is Chrystal. I'm a neuropsychologist, and today I'm going to be speaking more about brain injury. So let me see if my tech skills are working. Yes. So we have a little bit of time, but my goal is to try to go through a couple of different things, starting with a brief overview of TBI 101, talking about some of the persistent symptoms that people struggle with following brain injury, sharing some trends about brain injury in Arkansas, and then going over some of my favorite resources, sharing some of those with you. So to get us started, what is a traumatic brain injury? So traumatic brain injury, or TBI, my favorite definition is from the CDC and the Department of Defense, and it essentially reads that a TBI is a disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head, or a penetrating head injury with new onset or worsening of at least one of the following. So alteration of mental status, neurologic deficits, or intracranial lesion. Essentially, a TBI is a blow to the head, and that blow changes the way that the brain works. So there are two types of brain injuries that we talk about. We have open brain injuries and closed brain injuries. An open brain injury can have increased mortality because the brain is not supposed to be open to the environs, and that can be caused by something like a gunshot wound, which is a high velocity wound and has also increased mortality, or a low velocity wound like a stabbing. And we also have closed head injury, and this can be caused by something like a fall or a motor vehicle accident where the brain is moved, jostled, bumped, twisted in ways that exceeds the skull's capabilities to really protect it. So we have two mechanisms of injury that actually cause some of that neurologic dysfunction after that initial blow to the head. The first one is called primary injury mechanisms, and a primary injury mechanism is that actual initial point of impact. So this happens exactly at the point of injury and a couple of seconds thereafter. And what we see in the brain is a disruption essentially of how the brain works, bruising, diffuse axonal injury, and bleeding. Everything after that point we refer to as a secondary injury mechanism. So this is seconds, minutes, and hours, and even days following that initial injury. So here we see things like biochemical changes happening, changes to blood flow, swelling, intracranial pressure that can change, cell death cascades, inflammation, and a variety of more things. And the severity of symptoms that people experience from brain injury are typically related to these secondary injury mechanisms. And acute treatment is designed to manage secondary injury mechanisms, as well as kind of minimize further development of those, and also minimize any complications that can arise as a result of secondary injury mechanisms. So there are a couple of additional complications that can happen after a brain injury. Things like post-traumatic seizure, hydrocephalus, cranial nerve injury, midline shift, and more that we're trying to minimize the chances of that happening as much as possible. So regardless of the type of head injury, we classify head injury with three different levels: mild, moderate, and severe. So I'm going to try to use my little pointer over here. So there are a couple of different criteria that we can use to classify the severity of head injury. And you can either use a combination or any one of these. So the first one here is a GCS score, which is a Glasgow Coma Scale. And it is a scale that is used to measure three different things. So the first thing is a patient's best verbal response, a patient's best motor response, and then eye-opening response, or ability to meaningfully direct your gaze. And the best GCS that we need in order to properly classify head injury severity is within 24 hours after that initial injury. But usually the best one is taken as close to that initial point of injury as possible. So usually by MEMS or in an emergency room. We also have loss of consciousness that's used to determine head injury severity, presence of post-traumatic amnesia, and so post-traumatic amnesia essentially is when people have a traumatic injury occur to the brain. They can have a period of time, this happens across the board, especially with moderate to severe brain injury, where they're not able to really track events and make meaningful memories. That does typically resolve, but it can take a couple of days for people to get there. And then finally, we can also use structural imaging, so CT or MRI findings, to help us classify if something is mild, moderate, or severe. So I just want to draw your attention to some of the differences here between mild brain injury and severe brain injury. So first, one word here, mild traumatic brain injury is also referred to as concussion. So with a mild traumatic brain injury, you're seeing a GCS of 13 to 15. And if you look at the severe range here, you're seeing a GCS of 3 to 8. So a GCS lowest score is a 3. It's from 3 to 15. Loss of consciousness for a mild traumatic brain injury, someone may not lose consciousness, but can lose consciousness up to 30 minutes. And with severe brain injury, you see a much longer and sustained loss of consciousness. PTA can happen not at all or up to a day, all the way up to 7 days for severe brain injury. And then structural imaging across the board. People can have findings on CT or not, but typically for mild brain injury, CT findings are normal. Okay. All right, so let's talk about some statistics. So one of the leading causes of brain injury, almost half of brain injury, it results because of falls. Another one is being struck by or against an object, then motor vehicle accidents and other traffic incidents, and then assault. Those are the kind of the big four. The most at-risk populations for brain injury are children and older adults, so kind of at the tail ends of the age spectrum. And the reason for that is because sometimes at the age end of the age spectrum, people can have a little bit of motor difficulty, not have great balance, and so they can have more falls. Children, incidentally, make up about 1/3 of all TBIs that we see. Yet, despite the at-risk populations, the highest rates of brain injury occur in 15 to 24-year-olds. And the reason for this is because between 15 to 24 years old, people are kind of, getting their licenses, starting to drive. Maybe they have a little bit more risky behavior. They are legally allowed to start drinking. And so if you put those things together, you just have more increased risk for brain injury. Regardless, TBI is a major cause of death and disability in the United States, and as a result of that, a major public health concern, with up to 40% of people who survive brain injury going on to develop long-term disability. Okay, so when someone experiences a brain injury, what we understand is that they will experience what we call multi-system symptoms, essentially because the brain does everything for us. Any one of those systems that the brain is responsible for can be impacted. So you'll see things like motor changes, where people might have spasticity or hemiparesis. You can see sensory changes. Someone might have trouble with sense of taste, sense of smell after a brain injury. Many people go on to have vision problems. There are a host of cognitive problems that people have after brain injury. Psychological changes, so people may develop depression, anxiety, adjustment disorder, and in some rare cases, they can even develop mania and obsessive compulsive disorder. And then there are also a number of behavioral changes that can happen. So people can become more impulsive, they can be more mood labelity. People can have a little bit more trouble with initiation and motivation. And I don't even have everything listed on here because there's some other things that people experience quite a bit too. So like persistent headaches, fatigue, and then just a vulnerability to overstimulation. And for many people, sleep cycles can change quite a bit as well. They can't get good rest, which can compound difficulties following injury. So I'm a little biased because I'm a neuropsychologist, so I'm going to specifically talk about cognition just for a moment. Cognition is actually one of the most debilitating symptoms that follow brain injury. And essentially what we see is that specific cognitive symptoms or profiles will happen And the severity of those symptoms will happen because of injury characteristics. So for example, if you have a milder head injury, you shouldn't have as many cognitive symptoms, and those cognitive symptoms should not persist for very long, versus a more severe injury where you'll have symptoms that will persist for a longer period of time. Also with closed head injuries, you can see more diffuse cognitive changes, and with open head injuries, you might see more focal or specific cognitive changes. Of course, all of those cognitive changes are also going to be impacted by someone's pre-injury status, so what their brain health was like, what kind of cognitive reserve they had, what kind of access to healthcare they have, what their age is. Despite all those variabilities that you can have in cognitive problems after brain injury, most people, regardless of injury severity or injury type, will experience some change in their attention ability and their processing speed, particularly early on following their brain injury. Many people also go on to experience memory problems, usually because of the relationship between attention and memory. And then often people have executive functioning and social communication changes as well. And that's primarily because often in head injury, the frontal lobes are preferentially impacted just because of their location and the size of the frontal lobes. And the frontal lobes are responsible for our executive functioning. Okay, so I want to talk a little bit about cognitive recovery and TBI recovery broadly. So this is an old graph, but I really like it because it allows me to demonstrate some things, but the timing is off, and I'll explain why. So if we come over here and we look at this first line on the left, this is someone's cognitive level. And then we have time going across the bottom in months. I actually can't see the rest of the screen, but this ends here in 12 months, but this is because this was very early research. Early research what we knew about brain injury recovery was that people really only had a year. Since then, we've come a long way in understanding neurological recovery after brain injury. And so this is probably better understood as being 12, 18 to 24 months. So we actually have a lot more time for neurological recovery than we used to believe. But essentially, if you imagine someone kind of starting here at the more, slightly high average range, they're going along, and let's say they have some kind of brain injury, let's say from a motor vehicle accident. Anybody, whether that injury is mild, moderate, or severe, is going to have a sudden change in their cognitive level and kind of going to be around here. With a milder injury, they may not have any coma, any post-traumatic amnesia, and so their cognitive ability very quickly, especially around the 2-week mark, is going to pop right back up to almost baseline functioning. And by about 3 months, most people with mild TBI are going to have full recovery. Sometimes things can complicate recovery from mild TBI, primarily pre-morbid factors like a history of ADHD, history of depression, history of anxiety, and some other things that may limit treatment for people with mild TBI. But essentially, unless there are any issues, people tend to have a really good recovery. The difference with moderate to severe TBI, as you can see, is you have the same initial change in cognitive ability, and then you may have a period of time where there's coma, a prolonged period of time where there's post-traumatic amnesia. But around the 3-month mark, you're going to start seeing for both groups, moderate and severe TBI, a nice change where they're starting to have some improvement in their cognitive ability. That's going to go on and continue from 12 up to 24 months. It will plateau and recovery will slow, but there is a lot of opportunity here for ongoing recovery. However, with moderate to severe TBI, people don't necessarily always get back to their pre-injury level of functioning. That doesn't mean they don't get functional recovery, but neurological recovery can look a little bit different. So there has been a lot of research, as I said, about brain injury recovery, and we're learning new things from large studies. Brain injury is actually a pretty new field, and the reason for that is because back in the day, people didn't have the medical advancements to help treat those secondary injury mechanisms in hospital settings, and so many people with moderate to severe brain injury didn't survive. And so we're getting to see a lot more information now because of the medical advancements that we have. So some of the kind of highlights of what we're seeing in some large studies is that 77% of patients, even patients who are in vegetative states, which is a level of coma, at 2 weeks will regain consciousness. 77%, that's a high number. And within a year, they will gain functional independence in at least some of their ADLs for part of the day. So these people may go on to need something like home health care or some supervision, but definitely gaining functional independence over time. And as I've said before, there is a difference a little bit with functional recovery and neurological recovery. And with some of the longitudinal studies that we're seeing, there's a big one called the TRACK TBI study. We're still seeing neurological and functional changes at 5 years following brain injury, and then long-term functional recovery continuing up to 15 years as long as people are having good rehab and good supports. Speaking of support, one of the big differences between people who recover some and people who recover much more is social support. So it's super interesting, but social support is definitely something we want to prioritize. Regardless of all of the good news about more opportunities for recovery with brain injury, we also see persistent symptoms. And that's because if you think about the brain's ability to recover over a longer period of time, there's also a longer period of time where there's going to be chronic dysfunction in the brain. And because of that, you're going to see persistent symptoms that will continue. People also tend to struggle with ongoing adjustment to injury. So even someone who is 5 years out from their injury, super well adjusted, they might at that point decide, okay, I'm going to try to get a part-time job. And once they get that part-time job, because they are in a different environment with different challenges, that might brush up against some of the difficulties that they may not have realized in their at-home environment that they're really used to. So what we've learned is that people need ongoing adjustment to injury supports across time to continue to recover well and have good quality of life after brain injury. Okay, so I want to share some data about TBI in Arkansas. This data comes from the TBI registry that we have here in the state. Only moderate to severe brain injuries are recorded. And if you look here, you sort of have the regions that they're recording data in, so any of the hospitals in the areas, and then the number of referrals. So this data comes from a time period of, I think it's 2014 to 2021, let me see. 2013 to 2021, so an 8-year time period. And you can see you're getting sort of lots of referrals in the central region, the northwest region, and the north central region of the state. And if you look at the initial GCS that people are seeing most often, all of these brain injuries that are coming in are pretty severe. They also have a discharge GCS, so kind of looking at some of the improvements people are experiencing when they leave acute or progressive care units. So I also have a nice map that kind of details that. You can kind of see in these darker areas where there are higher numbers of brain injury survivors and recorded brain injuries coming in as well. There's actually a really good survival rate in Arkansas. I forget the percentage now. I should have looked at my notes and I cannot see them. But the survival rate for brain injury in Arkansas, the most important thing to know is that it's within national standards, which is great. But chances are, if you are working in Little Rock, for example, you are absolutely going to come across patients who have survived a serious brain injury, with 482 people just in Pulaski County with severe brain injury across that 8-year period of time. So I have a couple of recommendations that I think can be super helpful for patients with brain injury. One of the biggest things is being able to provide supportive education. The thing that I get told most often and asked for again and again is just come and explain these things to everybody. And what's happening is people with brain injury are not getting information about their brain injuries, and that's leading to a lot of misconceptions. The other thing is not to over or under pathologize mild TBI. So a lot of times people will come to me and they'll, be a year out from a mild TBI and they say, oh, someone told me to quit my job and never work again because I'm brain injured. Not true. We know that people with mild traumatic brain injury do recover and recover well. And other times people will have an experience where that brain injury was under pathologized. So they'll say, oh, someone told me I just had a bump on my head, and they go back to work. They do everything like they normally would. They're having headaches. They are having attention problems, and that can create anxiety and other issues, which downstream can just end up causing something like post-concussive syndrome. So the other thing that I'll recommend is early and intensive multidisciplinary rehab that's very personalized to your patient. So if your patient is not receiving rehab, absolutely refer them. We have great places here in the state. We have Baptist Health Rehabilitation Institute. They have a great outpatient program. UAMS has a great outpatient program. Also give shout out to Conway Regional. They have a great outpatient program. Exercise, diet, and sleep are wonderful ways to help improve brain health for people who have survived brain injury. Of course, social support being such a major factor in how well someone can recover is definitely something to recommend. If your patient is someone who unfortunately doesn't have a lot of social support, we can create that by increasing attendance in support groups, caregiver support groups, and also prioritizing caregiver training, which we also have here at UAMS. And then last but not least, if you have a patient who's had a recent brain injury, those were the do's. The don'ts are no drinking and then no risky activities. My rule of thumb is no alcohol and no ATVs, because that can be really a rough one. Of course, neuropsychology, if you have a patient who has a brain injury and has not had a neuropsychological evaluation, I highly recommend it, because we're able to sort of really objectively look at psychological change, behavioral change, cognitive change, and make recommendations that can help improve treatment. So you can call us, fax over referral, or find us in Epic as well. I also want to give a shout out to the brain injury group here at UAMS. This is a free service. If you don't know about it, I highly recommend you check them out. You can call, look at their website, email them, but they have so many different things, from case management to support groups to online workshops to a newsletter, as well as a conference that happens every year here at UAMS to help improve education for professionals with regard to anything brain injury related. They also have a 24/7 nurse hotline, which is awesome, because that is for medical questions for patients and their families, and also for physician consults. So I highly recommend checking them out. That being said, the brain injury group and the ACL group here in the state have funded a 14-week brain injury workshop. I developed the workshop a couple of years ago. This is a wonderful, wonderful free resource for patients who have brain injury. The only criteria is that the brain injury has to be moderate to severe, and the patient has to be over the age of 18 to attend. And we do cog rehab, we do adjustment to injury, we do brain injury peer support, which is amazing and really helpful. And then we also get them linked up with a bunch of different experts in the field to help address the different varieties of multi-system symptoms. Some of my other last minute, I'm looking at the time, favorite resources are the Brain Injury Alliance of Arkansas. They have all of the support groups in the state. Right now, we've gone from just having one support group in Little Rock to a support group in Conway, El Dorado, Heber Springs, and Batesville, or Bentonville. Don't quote me on that one. Something with a B. But check out that website, give that website to patients. We also have the Model Systems website, which I love. It has about, I think, at least 100 fact sheets on the different things that people can struggle with after brain injury. So things like sleep problems, sexuality after brain injury, different cognitive problems. So this is sort of another nice way to help with that supportive education by giving patients that resource. The Brain Injury Association of America have tons of free webinars for patients and their caregivers. And for providers, they also have webinars, but there's a small fee associated. So I definitely recommend them. The Arkansas Division of Workforce Services has a VOC rehab program that I absolutely adore. They do so much wonderful work. They help get people back to work. They can help people get back to work with an assistant, so they can have someone go with someone to work. They help with funding to get people back to school. They help with grants for people who would like to go back to work and have an idea for a small business. They also help provide free or low cost assistive devices to people who could benefit from them as well. And then the last question I get asked often is, many times after brain injury, people are asked not to drive and they want to go back to driving. So the best resource for that is having an on-the-road driving evaluation through occupational therapy at the outpatient group at Baptist Rehabilitation Hospital. So that is a resource for that. And I think, that is all that I have. Thank you.
That was so great, Dr. Fullen. Thank you for that.
Thank you.
And I think we have one question in the chat, but I'll get us started here.
Okay.
May you go back just a few slides to that 14-week, that right there that you developed. What I thought was so interesting, down that second to last bullet point, music therapy. Whenever I see older adults that may have one of the various types of dementia, major neurocognitive disorder, I'm starting to see in the literature music therapy kind of emerging as one of the useful non-medication interventions for folks that have dementia. And a lot of times trainees, that are watching this, folks that are reading about music therapy, they're like, what is music therapy? Is that just like listening to music? And so could you explain for our audience and folks here, like what that looks like for someone that has a brain injury? What is music therapy and how do they do that?
Yeah, so I'm not a music therapist. I'll start by saying that. We have music therapists come to our group, and the understanding and sort of research behind that is that one great thing about music therapy is that it provides really nice cognitive stimulation to patients, which can be super helpful. The other thing that it helps to do is when people have some communication deficits and problems, music is a different way for them to be able to communicate. So some people, for example, can have certain types of aphasia, but then still be able to sing. And so music therapy sort of activates different parts of the brain that are important. The other thing is music therapy just across the board tends to boost mood, and so people really enjoy it. And what we like to do with this workshop as well is provide a lot of more traditional types of rehabilitation medicine services like PM&R, for example, in psychiatry, for example, but then to add to that some CAM or complementary alternative medicine in order to sort of really kind of boost and tie together a more holistic medicine approach. So we'll do like yoga therapy as well. We've even had animal assisted therapy to really just give people an idea of all the different ways that recovery can look.
Thank you. Thank you. I'll go ahead and click that in the chat there, see if I can pull up the, let's see here. Someone's got a question, I think. Could you provide that email address again, please?
Sure. I wonder if it's this email address or if it's the yeah, it has to be this one.
All right. Braininjury@uams.edu.
That's pretty easy to remember.
Yeah.
Yeah, very simple. All right. Does anyone have any questions for Dr. Fullen in the audience here?
How large are the support groups typically?
That's a great question. So usually we do two. So we always try to we offset them. So we do one in-person group because we only do that in Little Rock. And then we do the next one that we run a virtual one. And so with either of them, we try not to have more than 10 participants. It is a pretty large group. But usually, like with any group, there's a little bit of attrition. So usually we've had as small as 6, and then we've actually sometimes had as big as 12 participants at one time. But I think the smaller groups are kind of nice because it allows everyone to really get to know one another, although that invariably happens anyway because it is 14 weeks. So, yeah.
Thank you.
Yeah.
If a provider is seeing a patient who's had a TBI, I know you mentioned the referral into neuropsych. At what points are good points for referral in? Do they need repeat assessment? What are your recommendations around that?
Yeah.
And I know you also do cog rehab, so any things related to that.
Yes, I'm so glad you asked. So I think there are different approaches to this. I'm one of the people that really prefer serial assessment because I think if the more assessments you have, the more opportunities you have to adapt and amend a treatment plan to make sure that when people do have the most neurological recovery, we can boost that by creating more opportunities for tandem functional recovery through rehabilitation programs. So essentially what I think is nice is people are always going to get some level of cognitive and psychological assessment when they're inpatient, various points. So I think making sure you are having a neuropsych eval within that first year of recovery, probably around 6 months following injury, is nice. And then once you get to a year or 18 months, having another one so that you have another opportunity to still catch some more recovery, neurological recovery time, in order to, like I said, boost those recommendations for functional recovery through rehab. And then with cognitive rehabilitation, I recommend all of the cognitive rehabilitation as early as possible. So as soon as someone has had a brain injury, I think you can't get enough OT, PT, speech, adjustment to injury, different types of therapies, those complementary medicines, and absolutely cognitive rehabilitation as well. Primarily, if you have a patient, even if they're like 5 years out from their injury and they've never had a neuropsychological assessment, I would still recommend that. And even if someone is 10 years out and they have a new goal or they're having new problems, usually a course of rehabilitation can really help them get back on track. So I'd also recommend that.
Well, thank you so much, Dr. Fullen. We're at time. If folks have questions in the chat or would like to hang around, we'll be around for a little bit. But that was great. Thank you so much.
Thank you.